The session will be recorded, and it's my pleasure to be introducing Dr. Judy Maro. Dr. Maro is an assistant professor in the Department of Population Health at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. She received her doctorate in engineering systems in Massachusetts at the Massachusetts Institute of Technology, or MIT, and her main research interest is the implementation of pharmacovigilance techniques, particularly continuous near real-time sequential statistical analysis methods and data mining, and signal identification methods in distributed longitudinal databases. Dr. Maro is also the operations lead for the Sentinel Operations Center as part of the US Food and Drug Administration's Sentinel system. So it's my pleasure to introduce Judy. In the interest of time, what we'll do is we'll ask folks to save questions for the end. If you want, you can pop them in the chat as we're going. And we'll circle back to them near the end of the talk. And with that, Judy, if you can share your screen, the floor is yours.
Okay. Can everybody see my screen?
Yes.
Thank you. Thank you for that. So hello, everyone. I'm super thrilled to be asked to present today. I'm going to be presenting on surveillance of adverse infant outcomes following maternal medication use during pregnancy using tree-based scan statistics. I'm going to be presenting on behalf of a work group that we have in FDA's Sentinel system. We call it the Tree Scan and Pregnancy Work Group. I want to acknowledge that group includes many folks who I've listed here, both where I work at the Sentinel Operations Center at Harvard Medical School and also at the US Food and Drug Administration. I want to particularly emphasize the work of Elizabeth Suarez, who created most of these slides. She's a postdoc that's been working with me for a couple of years now on these projects, and she's critical to the work that we've done here. And so without further ado, I'll go ahead and get started. We're going to talk a little bit about the motivation for why we did this work, review some of the tree scan based methods, talk about the two different aims of the study. One was a simulation analysis, the other is a case study, and talk about some conclusions of the work. I guess, and I even don't have a slide here, but I'll say before we get started, for folks who are coming, I think a lot of people are familiar with the Sentinel network, but I'll just say that we're the American CNODES, if that makes sense. So we work with our Canadian friends all the time, and I'm thrilled to be able to have several projects where we've had collaborations. The use of the common data model has been excellent and a unifying factor for us to be able to do multi-country work. And so I'm super excited to be able to present this to you today. And so when you think about this, you could think about it as something that, although we are doing it through the Sentinel system, it could easily be ported over to CNODES, particularly because of the use of the common data model. So some things about why we might be interested at all in using signal identification methods for drug safety and pregnancy research. So I'm going to review, sort of the state of affairs, but I think it's probably familiar to many of you that pregnant women are rarely included in clinical trials during drug development. And therefore, a lot of information on teratogenicity and other potential adverse effects are collected in the post-market. And so one primary source of data in the post-market is a pregnancy exposure registry. These pregnancy exposure registries enroll individual patients at any time during pregnancy and then monitor them for outcomes both for the mother and for the baby. But pregnancy exposure registries often miss enrollment targets, and the registries themselves are often underpowered for specific individual malformations. And so administrative claims databases and other electronic health record databases can be used to complement the data that are available in registries. And of course, the main difference being a registry is a primary research method where you're actually gathering specific data, whereas in administrative claims data or EHR, that's typically what we think of secondary use data, where we take advantage of the fact that there are very large populations already available, and we look at those populations for information about birth outcomes. So when we do pregnancy research often, especially in targeted studies, there has been a requirement for outcome validation. And that can be resource intensive when we have multiple individual malformation outcomes we might be interested in as in the case in signal identification. So what is signal identification and how is it different than a targeted study? Well, signal identification, the way we define it, is a systematic evaluation of potential adverse events related to the use of medical products, but without pre-specifying or targeting any specific outcome of interest. And so what we're talking about here is a set of outcomes that can number anywhere from the hundreds to the thousands to the 10,000s. And the idea here is that we're doing a screening analysis where we're looking for new and unsuspected potential safety concerns, and we're screening broadly so that we can have a safety net where we capture new information. A signal identification study can point to areas that need to be prioritized potentially for future studies. And so there's the transition here, and I'll show this in a slide in a minute, of taking something from a signal identification phase into a signal evaluation phase, and the main difference being the targeting of the outcome itself. And so one of the reasons we would like to do this in administrative data is just to take advantage of these very, very large sample sizes. And the other piece is that we aren't really limited to a single outcome like major congenital malformations, which even that is a composite outcome made up of many individual specific malformations. And so in the signal identification process, as I alluded to, we start out with this large set of data that we're using our data mining tools to assess a very large number of outcomes for a single exposure contrast. And then we take a look at the results of these data, and we have pre-specified what we deem to be an unusual sort of we observe an unusual number of events when we compare our treatment group to our comparator group. And then what we want to do is we want to look and see, what is it about these events? Are they explainable because of the label? Are they explainable because of other things that we know about this particular condition? And we look at patient episode profiles to try to understand if there are other causes potentially for what we're seeing. And at that point, we actually use a transition in phrasing between calling something an alert to calling something a signal. So in some ways, we're graduating it to now thinking about it much more seriously as the focus of a targeted pharmacoepi study, which is, again, this last step. And this is where you would see a specific observational study that was designed around that particular exposure outcome relationship with tailored confounding control that was definitely looking at that particular association. And so I'll review the signal identification methods that we use, which are tree scan based. And so this supports multiple outcome study designs through the use of the tree scan tool. And so what is tree scan itself? It is a freely available statistical data mining tool that can be used for signal identification in pharmacovigilance and pharmacoepidemiologic analyses. And you can see there's a link in the lower left-hand corner. Actually, a new version of tree scan was just released like 3 weeks ago. So I recommend if you haven't downloaded it for a while and you've used it before, you refresh it. And essentially what it's doing is it belongs to a family of methods that are called scan statistics. And what scan statistics do is they scan data. And you can think of a data set in many ways. There are geographical, regions in a data set. There could be time that is your thing. And you can think of it like a box that's like scanning over all of these data and looking for these unusual clusters of events. And so when we see an unusual cluster of outcomes in a treatment group relative to a comparison group, that cluster could be an individual outcome, which is very specific, for example, atrial septal defect, or it can be an entire grouping of outcomes. So congenital malformations of the circulatory system. And tree scan is a formal way to actually find those clusters. It adjusts for multiple scenarios through the use of a composite null hypothesis testing scheme with Monte Carlo simulation that holds type 1 error due to chance alone to be constant at a user-specified threshold. It's compatible with multiple epidemiologic study designs and confounding control methods. And here are some examples of when tree scan was used in the past. So this is an early publication on tree scan. Martin Kulldorff authored it. He is the inventor of tree scan. And so this was using Poisson-based statistics and one of the first ventures into drug safety data mining. We've also done a lot of work in vaccines. And so this has been used extensively with temporal tree scan statistics. It was then brought into drug-based work with propensity scores by my lovely colleague, Shirley Wang. And it's been used to try to bring the propensity score adjustment into tree scan in several ways. And then it's also been used by other folks. Krista Hubrechts and her group have also done active surveillance of safety medications during pregnancy. And so again, this is just a slide to go through what are the differences between a signal identification study and a targeted study. So right now we start out with, cohort identity is the same, right? We're looking for pregnant women and we're looking for their infants using usually a linkage in order to ensure they're part of the same dyad. We then look at exposure records and we use those exposure records to classify our exposed population. We typically think of this as very good in secondary use data. And then the difference here is how the outcome is identified. So again, in a targeted study, usually that outcome is a validated algorithm for one particular outcome or group of outcomes. For example, cardiac malformations as a composite outcome. But here we create an outcome tree, and I'll show you an example of an outcome tree in a minute, because again, we're doing this screening analysis across many outcomes. Both a targeted study and tree scan have the ability to use confounding control with propensity score methods. But then in a targeted study, you would calculate a point estimate and confidence interval for a particular exposure outcome association, where here we are calculating test statistics for each outcome using the tree scan software. And what a test statistic essentially is a threshold. And when something comes in above that threshold, you're essentially saying, this is something that's really unusual, and maybe I need to look at it. So again, in a screening study, the idea here is to draw your attention or prioritize it to potentially outcomes that are concerning, but we're not yet clear about whether that we already know about them or there might be some other reason for that increased elevation of adverse events. So this is an example of an outcome tree. And so again, if you can think of a scanning scenario or moving like a box or a piece, around a data set, right? It's moving around looking for all of these particular outcomes. And so we start at the way a tree works in tree-based scan statistics is you can think of a tree as being upside down, where the bottom is the leaf. So this is the finest sort of division of an outcome that exists. In this case, it is an individual ICD-10 diagnostic code. And then as I move up the tree or more towards the branch or going towards the trunk, essentially I keep grouping these up into more aggregate groupings of the same phenomena. And so here, you see these very specific codes at the bottom. And then by the time you get up here to level 2, you're looking at congenital malformations and deformations of the musculoskeletal system. So this is really broad. These are very fine. Other trees that are utilized in pharmacovigilance and pharmacoepidemiology that you might be familiar with, the MEDRA terminology. So the terminology that's used in adverse event reporting systems and also in clinical trials. The equivalent of the leaf or the lowest level there is the lower level term, whereas the system organ class is the equivalent of the upper term. But the idea here is simply to be able to look at multiple levels of a potential outcome, because you may not be, when you're doing a screening, you're not thinking about, what data ahead of time that suggests a very specific issue versus a very broad issue. And so you check them all as a way to show how this works. And so this is just indicating that as we go up the tree towards the lower numerical numbers, is what we call it, we're getting closer to the trunk and getting these bigger categories, and that we test at all of these levels. So outcomes that we included in the infant outcome tree were major congenital malformations. We excluded some minor malformations based on guidance from the World Health Organizations. We also included conditions related to gestational length and birth weight. So when we looked at this using tree scan, we looked at potentially multiple tree scan based methods. And so I'll talk a little bit about those. So first, the hypothesis test that's being tested when you use tree scan at all. The null hypothesis is that there is no increase in risk across any outcome in the entire tree. So over as many outcomes as you have in that tree, which again can be in the thousands, in the exposed group, where the alternative is that there's at least one position on the tree where there is an increased risk, or basically an increased number of identified adverse events that's unexplained in the exposed group in particular. And again, formal adjustment to ensure that we are adjusting for our multiple scenarios using a composite null hypothesis testing scheme. There are 2 different types of probability models. One is a Bernoulli-based model and one is a Poisson model. Really, the important takeaway from them is that they treat the referent population differently. In both cases, there's a comparator population, but they are used in different ways to calculate the expected outcome count that would be in the exposed group. And we've seen, and I will show you in subsequent slides, that a Poisson version is expected to have greater power. We typically say when we are going to start to pay more close attention to any particular outcome, which we call a statistical alert, and we can pre-specify that at any value. A very typical one is a p-value of 0.05. And again, just because something is crossing the threshold to be an alert, we don't yet call that a signal until we've had time to look at it and investigate it and feel that it merits being graduated to that higher level. So we do use propensity score-based methods with TreeScan. There are two different flavors that can be used. One is a fixed ratio propensity score or other form of exact matching. In this case, you would match a referent group of patients to an exposed group of patients in a pre-specified maximum distance in their propensity score and with a fixed ratio. So it could be 1-to-1, 2-to-1, 3-to-1, et cetera. One of the advantages of this is it allows for very strict confounding control because within that matched group, you have very good exchangeability. And that can be used with the Bernoulli-based TreeScan model. We also can do a stratification approach or a fine stratification approach, which takes weighting into account, where we would create percentiles of the propensity score distribution, and then we assign the exposed and the referent group patients into those individual strata based on their propensity score value. One of the advantages of this is that it allows for the full use of the population after, of course, we do trimming. So we'll essentially remove individuals that really have no appropriate match or appropriate just overlap, essentially, in the propensity score. And this stratification or the fine stratification approach could be used with the Poisson-based TreeScan model. And so in the study that we did that I'll talk to you about today, we had two different aims. The first was a simulation study to assess the performance of TreeScan under known conditions. And so I should say that we've done a lot of work. The FDA, specifically in the Sentinel Initiative, has supported a lot of development work in TreeScan. And it is very typical for us to take this two-pronged approach where we use a simulation study in one case and a case study in the other. And that's because they both have just different advantages. The simulation study allows you to actually, set a ground truth that you've set, what it is, so then you can go ahead and check the ability of TreeScan or any other type of signal identification program to detect that ground truth that you've already pre-specified. So it's like the equivalent, obviously, of a controlled experiment. Whereas a case study, an empirical data study, you aren't setting that ground truth in advance. And you could find something that you didn't know about or you were surprised about. But one of the advantages of an empirical study is that you have the messiness and also the complexity of real data, which sometimes, even when using very advanced simulation methods, can be hard to mimic. And so we typically do this piece where we do a simulation study and we do an empirical study. Really, all of these study aims were geared around the idea of how do we routinely use this method in a secondary use database to monitor for adverse effects or birth defects, after in utero exposure. So we were trying to get to the point of how do we best use this technique? What can we learn from it using the simulation study and the case study? Because we want to start using it routinely. And we want to use it routinely in the same way in order to monitor for the safety of pregnant women and their infants in that post-market environment. And so with the simulation analysis, we went through, and I think I just basically said all of these things about the simulation study, what we tried to do. We're mostly interested in power. We know based on TreeScan's method by design that we will keep type 1 error control due to random chance. So we were very concerned with sort of what was our false negative rate? What power did we have to identify any particular outcome at any particular position on the tree? We were also concerned with bias control, particularly related to the outcome. I will get to that in a minute, but I should say that there has been other simulation work, which I showed in some of those papers earlier, that that my colleagues have done with respect to misspecification of the propensity score model and that ability to impact errors. And so we didn't want to repeat some of that work. We wanted to sort of go in a different direction. And so another thing that is true about the tree scan simulation studies that have preceded this study was they were mostly done in a general adolescent and adult population using a much different outcome tree, which was actually much bigger. And so we were interested in seeing how the tree that we've used performed and this very specific population. One of the other things about pregnancy studies is we expect, unlike some of our tree scan studies that we've done previously, to have a very small exposed population. So if you can imagine the difference between a vaccine, for example, where we routinely see 1 million people exposed in data, to something like a pregnancy study where we expect that very few women are going to be exposed to this drug, there is a need to understand how the method performs under those various considerations. And for us, a simulation study helps us to understand more about those pieces. So we specifically were looking about, which of the different statistical methods, whether we use a Bernoulli or Poisson, can have increased power. We know because there are related sets of methods in sequential statistical testing that Poisson is more powerful than Bernoulli. So there was a question about whether that extends essentially to the tree scan scenario, or to the signal identification scenario, I should say. And we also were interested in the potential for outcome misclassification in administrative data. So one of the differences, again, hearkening back to pregnancy exposure registry, is an exposure registry. You expect those outcomes because they have been they've been recorded through direct interview, potentially with pregnant women, to be not have some of the outcome misclassification you might see in administrative data. And one of the reasons like administrative data often uses validation studies is to get basically to work around that outcome misclassification. So we wanted to understand sort of what the impact was of outcome misclassification on our study. And so for our simulation methods, what we did was we used empirical data to start with to seed our understanding of the outcome tree. So we used background incidence rates, and we created data sets for a referent group and an exposed group using some of the data that we already had. We simulated these cohorts with known increases in particular outcomes. So what I mean by that is we injected risk in particular outcomes that we pre-specified at varying levels so that we could then check about TreeScan's ability to then pick up that injected risk. And we use software functions that are native to TreeScan themselves to actually look at this power. And so we looked, again, one of our interests was understanding which method would be more powerful, with our hypothesis being that if what we knew from related methods are true, that we would expect Poisson to have greater power. And so that was one of the reasons that we looked at both of these pieces. And these are some, results. So I'm going to take a minute to orient you to this data because it's there's a lot going on in these graphs. So let me start out and say at the top, we have a Bernoulli method, we have a Poisson method. In each box, we have a number of exposed persons. So you have exposure increasing as you go up here. We have also a number of different effect estimates. So we start out with a modest effect estimate, and we work up towards a more severe or extreme effect estimate. Then we also have varying outcome rates. We start from our most common outcome rate, and we chose outcomes for just sort of to make it easier to understand, but really you shouldn't take away anything from these specific outcomes. Everything is simulated here. So this is really just about having a common outcome, moving to a much more rare outcome in terms of prevalence of the outcome in the population. And so what I want to orient you to just sort of by just with these Bernoulli is, as you would expect, and I'm sorry, this is all power that you see here. And so when you increase the number of individuals that are exposed, you have power that increases. When you seek to detect a risk that is larger, it's more severe, you have more power. And when you also are looking at a common outcome rate, you have more power than when you're looking at a very rare outcome rate. So this should just jive with sort of your understanding of how all of these pieces move together. But now I want to draw your attention to the contrast between the Bernoulli data and then the Poisson-based data. So you're using the same simulated population, you're just using a different method to go about creating your reference population and then doing your analysis. And so here you can see the differences right here in this most common event around the 4,000 to 8,000 exposed sample sizes, where we have greater power here in the Poisson. And you'll see that throughout. So you can see greater blocks, if you would, of green coloring, meaning power that we're really happy about. And you'll see, and obviously that's true all the way across there. And so conclusions here that Poisson has greater power than Bernoulli, which is consistent with the expectation that we had walking into this based on what we know from sequential surveillance that is targeted and not related to numerous outcomes, but is related to one particular outcome. And that a minimum of 4,000 exposed pregnancies is what we're thinking is our rule of thumb necessary to observe a doubling in risk of common outcomes with approximately 90% power. So we often get asked, so what will you recommend going forward about when we should do signal identification? And I'm going to tell you that I'm going to recommend that we do it even when we don't have 4,000 exposed pregnancies. But one of the reasons that we want to know this information is we want to set expectations of what we actually can detect under various circumstances based on the data that are available. And so a second question was, can we increase the power by using, essentially by manipulating our matching method so that we add more controls? And if we, one of the sort of key features of this is that the Bernoulli-based tree scan method requires a fixed ratio match. And it's really important to keep that in mind, because what happens is if you find, a second match or a third match, you need to have second matches or third matches for everyone in your exposed population. And so that's where the overlap that you observe is going to become really important. So when you have a very large referent group, it's probably fairly easy to continue to add more referent patients to increased power. But if the referent patients are too distant in terms of their overlap from the exposed population, you actually can decrease power, and we'll see that in a minute. And so we simulated different propensity score distributions with varying levels of overlap to sort of get at this question. Knowing that going into this in the future, we may want to be doing this again for many different exposures, and they may have very good active comparators, or they may have very poor active comparators. And we need to be able to sort of adjust to whatever we have as a circumstance. And so we simulated a propensity score distribution with very good overlap with an active comparator here in sort of population A. And here, the base population here, we had a certain number of simulated exposed pregnancies and then comparator pregnancies. And we extended that to be quite large in the unexposed pregnancies, because this is what we see in reality. There are many, many more people who are unexposed to pregnant and unexposed to a particular drug of interest than exposed. So this is our good overlap scenario. This is our mediocre overlap scenario. And this is our poor overlap scenario. And then, of course, this is our unexposed comparator. And so how do we see behavior change? So we're going to keep, for these results, just to sort of keep moving parts at a minimum, going to go with the most common of our underlying rates. And we're going to look at the matching ratio here as we increase and we add more referent patients for each exposed patient. And so here to remind, this is our good overlap scenario. So as one might expect, with a good overlap scenario, we can easily add referent groups of patients without losing exposed patients because they lack the ability to find a second match or a third match. And so we see power increasing here as we go up. Now, when we go to our mediocre overlap scenario, here, you could see that we are adding referent patients, but we're losing exposed patients now more rapidly, because every referent patient that we add, we don't necessarily have one for our entire population. So here you see power start to increase, but then quickly decrease again. And I'm assuming if we went down 4-to-1, we just keep seeing it dive. So essentially, there is there's a limit to the ability of the mediocre overlap for you to increase power by increasing your matching ratio. Here in our poor overlap scenario, this is just, it's terrible to begin with, and that just gets worse, essentially, as you try to add more referent patients. You just do more poorly in terms of how many people you have. And then this is our unexposed comparator group. And one of the advantages, again, of the unexposed comparator is that the number usually of unexposed people is very large. You have this huge pool to choose from when you're adding referent patients. So you can add them without losing too many individuals, although you start out with less overlap to begin with, because you have this propensity score distribution is very typical, where you have really big differences between the sizes of your population, where it's hugging that propensity score lower level of 0. And here you do have this increasing power as you go up. And so what we saw when we were doing this was that power can be improved when there is good overlap, or when you have an unexposed comparator. But you really have to be careful if you have anything less than good overlap, because you may end up losing more exposed patients than you would otherwise want to. And so finally, we took a look at the influence of outcome misclassification on power. And this was really important because we were thinking about, when we're doing a scanning scenario, we are going to be scanning all the outcomes in the same way all the time. And so what we have been using is the presence of a single diagnostic code in any care setting that meets its appropriate incidence criteria, which is usually based on, it's different for pregnant studies versus non, but the bottom line is we don't want to double count. And so we require there to be some incidence. And so what we wanted to think about was, do we require a single outcome in any setting, or would we routinely want to require 2 outcomes within a given time frame? And the trade-off there is that we think that when we require 2 outcomes, because we are getting more specific, we will, in fact, end up with a better positive predictive value. When people do qualify as having 2 outcomes, we can be more certain that that is a true adverse event. But there is oftentimes that you lose actually some true adverse events where there just isn't a second diagnostic code. And we saw some data in particular in Medicaid data to support concerns that we might really lose a lot of people if we were to implement such an analysis. And so we wanted to think really hard about, when we do this screening analysis, what is the best way to do it? And so we think our definition of just having 1 code in any setting is going to be sensitive, but not as specific as an option where we would do 2 codes. And so one of the possibilities of this is that when we have the potentially noise in our system, a lower positive predictive value, that we can then reduce our power by biasing our effect estimates toward the null. But we also know that if we have very low sensitivity, we're going to have limited power just because we're going to have a smaller number of people that ascertain in our data set overall. So then this trade-off becomes, what's the worst thing? Is it worse to have when you have to make these trade-offs between positive predictive value and sensitivity, what might you do? And so we know we needed one sort of thumb rule to do a broad screening analysis. So we wanted to take a look at it. And we wanted to see what was going to basically have the best performance. And so we did a bias analysis through simulation to address this. And we used various combinations of sensitivity and positive predictive value. We created data sets where they were known biased, if you would. So basically we created, you could think of it as true data sets of adverse events. And then we created the misclassified version of that true data set with certain assumptions in mind. And then we checked TreeScan's ability to look at picking up the true value and then look up the misclassified value and took a look and see what our power was like under those circumstances. And so here are the results from that. Again, there's a lot going on in these graphs, so I'm going to just spend a little bit of time orienting you to the graph itself. So here we have 2 different outcomes of interest. One is occurring, this one over here, more commonly than this one. We have the number of, we kept, so for this demonstration, I'm showing you the effect estimate is held constant, but we are showing you a different number of people. So we're increasing the sample size here as we move down these boxes in terms of the number of people in our exposed group. So if I just draw your attention to the perfect PPV perfect sensitivity scenario. So again, the ground truth, if we had the ability to have no outcome misclassification in the ground truth, what would we see? And you could see that power does increase as it should, as you get higher in your, basically as you increase your exposed population, you should have more power. We also see that you have more power when you're looking for a more common event. So if you just focus for a minute on just this lower right-hand box in all of them, it should make sense with what you're used to in terms of the way relationships behave. So then what we want to think about is, okay, when we start to degrade sensitivity, so we start to move leftward here, or we start to degrade positive predictive value, where are we having more losses? Where are we more concerned for our loss in power? And so what we see here, and we see is that while they look, basically that they're not too far away from each other in the sense that there's not exactly, a hugely clear winner on this side. But we do tend to believe that we're keeping our power a little bit better when we keep our sensitivity high. And so when we're looking at, these data together, our feeling is that, especially in a screening analysis, that we would like to prioritize sensitivity over positive predictive value, although acknowledging that losses in power due to degradations in either of them, obviously is not ideal or optimal. And so here we did the same study now with a Poisson-based model, just to see, sort of if there's any change. And we have kind of the same results here, where, for the most part, this one looks like straight down the middle. If I put, if I put a line like that, I wouldn't see any difference. But over here in my more common event, I'm seeing more power retained over here. And then so on and so forth. I can go through and put this imaginary line, down each of these and sort of look and see where am I retaining more of my power? Where do I prefer to be? And so we think there's slightly greater power when we maximize sensitivity versus maximize PPV. And so in choosing an outcome definition, we decided to stick with our outcome definition where we only require a single outcome in any setting when we're doing a signal identification analysis versus 2 outcomes with a requirement that they be within a certain number of days of each other, for example. And we're accepting the fact that we believe that while that's sensitive, it may be less specific, and that might cause us to have alerts that are later shown to be not real adverse events because they were maybe a rule out diagnosis, for example, or something like that. And so our simulation conclusions, we recommend using the Poisson model to increase power to observe alerts. A potential disadvantage of using that is that our exchangeability might be different depending on how big we make our strata, for example, because keeping in mind the stratification approach is the one that's works with the Poisson model, whereas the matching approach is the one that works with the Bernoulli. So obviously the size of that, either, when you have a little matched population or whether you have a stratification population, depending on the sizes of those, it's all a scale, but there's more exchangeability typically when you have these smaller groups with more smaller distances between their individual propensity scores. We looked at whether we could improve power with the Bernoulli method by increasing the number of referent patients that were matched, but because we're required to keep this fixed ratio matching strategy as a result of the mathematics behind the Bernoulli-based scan statistic, it's something that you can use in every circumstance. It really depends on having a good active comparator with good overlap, or potentially having an extremely large population with an unexposed comparator. For us, power was more important than confounding control. Because when we do this, again, this idea here is progression from a signal identification framework into a signal evaluation framework. And we know when we go from, just even thinking about it, taking a step back, signal identification is thousands of outcomes. You can't have confounding control that actually precisely targets all 1,000 of them at the same time, or 10,000. So you know that if you're going to see something, you're going to migrate to this targeted study where every confounder is selected specifically for its relationship, et cetera, in an evaluation study. And we kind of count on that. And that also lends a hand to how we think about a signal identification study versus a signal evaluation study, where we know that when we get to that targeted study, much more can be done in confounding control if need be. And so our outcome misclassification analysis suggests that we have a highly sensitive outcome, and we favor that over a highly specific one, regardless of the tree scan model used. And so I'm going to pause there for a minute to see if I can get a time check, because I don't have an ability to see a clock right now, before I go to the second part of this aim, which was our empirical work of a case study of fluoroquinolones and cephalosporins in the first trimester. So can I ask my Canadian friends if I
Judy,
have a time check?
I got 12:41.
Okay. All right, so I will try to keep some time for questions. I will try to go through this part very quickly. So we wanted to demonstrate the use of tree scan in real world data with a real example, but knowing we didn't set the ground truth there, so we didn't know exactly sort of what was there and then detect it. So here we were looking at exposures in the first trimester, fluoroquinolones and cephalosporins. Both were expected to be safe, no expected safety issues. Now you could say we could have chosen potentially a known positive, meaning where we know that there is a concern based on a known teratogen. We didn't choose that on purpose. And the reason is we were concerned about the sample size in those circumstances, that essentially if it's a known teratogen, that women really shouldn't be exposed to it. And even though we do see exposures in pregnancy that we really shouldn't, that we shouldn't see a lot of them. And so we wanted to try to do something where we wouldn't have that circumstance. So we chose something that we know was safe. And so we were expecting to see no new alerts in this empirical analysis. And so here is just a quick look at what's known about fluoroquinolones. I'm going to go through this quickly because I don't think we'll have time for everything. The study design, we used IBM Market Scan research databases. We looked in the ICD-10 era only among women aged 10 to 55 years with live birth deliveries. And we required those women to be enrolled for all of the time leading up to their delivery and a 90-day pre-period. We used a delivery washout, which just means essentially that we made sure that there weren't multiple deliveries that were too close together for reality. We looked for exposure to be in the first trimester. We excluded women who were basically exposed to the opposite study drug, and we also excluded women who had teratogen exposure during that same time frame. And we looked for birth outcomes in the days after delivery up to 180 days. And my understanding, not being a clinician, but that birth outcomes really are present much earlier. And this is about the detection window, when we would detect that they existed, but they don't all of a sudden, happen sometime at like day 145 or something like that. So with propensity score models, we used multiples of them to try to look at how different propensity score models would work with this particular analysis. We started out with a generalized model. This is mimicking work that was done by my colleague Shirley Wang. She built a general propensity score model for an adult population. We built one for a pregnant population using the same kind of ideas. We then took that general model and added indications to it so that we could control for a preference for particular uses of antibiotics. We also tried a high dimensional propensity score model. And again, this is an approach that we've used before where we've tried multiple models to see what we thought was the most appropriate. When we looked at these models to build our propensity scores, we were looking at baseline characteristics, including pre-existing conditions in the 90 days pre-pregnancy through the first trimester for latently recorded conditions. We looked at the age at the time of delivery, and we looked at healthcare utilization and screening in the 90 days before pregnancy. We looked at indications around the exposure date. And we did both a match design, so a Bernoulli-based design with a different fixed ratio matches. We also did stratified designs using the Poisson-based model. We settled on deciles of the propensity score, and we did some other sensitivity analyses with incidence criteria and outcome definitions. And so I'm going to talk through these analyses. This is just a really brief look at the different propensity score models and how they look. So you see here is the general model. As we add indications, we get more differentiation between these red and bluish bars. And then when we add a high dimensional propensity score, technique, we get even more differentiation. So we start to see more separation as we add more covariates. Here are our results using our propensity score matching in our Bernoulli model. So our number of fluoroquinolone exposed pregnancies here is around just under 1,800. And we end up with, we have many more cephalosporin exposed pregnancies, but in the matching scenario, of course, we go to the match. And so we have around, all of them get matched that had one in the 1-to-1. And then as we move to 2-to-1 and 3-to-1, we start to lose some of our exposed population as we have matches. What this shows here, the number of cases, what that is, that's the total number of observations for all alerts. So it's like the all outcome load, if you would, during that time frame is listed here. And what we saw here was we saw one alert that was in the Q31 group, or congenital malformations of the larynx. And it was significant, but only in our one-to-one matched general model. As we added more refined confounding control, we added indications, we added potentially more individuals, we saw this go away. So this alert was not robust across models. And this is a good example of how we do this triage, this following up. And so what did we do as well? We looked at the particular alert, and we looked at the split of cases. So the differences here in the imbalance between the fluoroquinolone and the cephalosporin population. And we took a look at the actual patient profiles that were related to congenital malformations of the larynx. So what is this? First, it's essentially a presentation at birth or shortly after of a dysfunction that essentially makes it harder for infants to feed. And oftentimes it is a mild case that's resolved in a period of time and managed with acid suppression, speech and swallow therapy, and high calorie formula for feeding problems. So we took a look to see of this particular malformation in this, again, one analysis, which was not robust across, do we think this was a real problem? And when we reviewed all of our claims profiles, we saw, and we reviewed these with our FDA colleagues, that many people did not have serious sequelae. So it appeared once, it did not appear again. It was generally associated with a feeding problem. It could have been part of the differential of a feeding problem, but we didn't see it persist. And so we looked at this and we thought that it potentially was due to uncontrolled confounding, because we theoretically, it resolved once we added more confounding control with indications with the high dimensional propensity score. So we didn't end up following this up. But this is an example of a triage process where we took something that had a statistical alert and we did not graduate it to a signal. We did not think we needed to actually look at it more in depth than that. And so I'm going to go through the stratified design results right now. The one difference in terms of the cohort identification with the stratification approach versus the matched approach is we required because of the way that referent outcomes are calculated, we required a period after delivery of being enrolled to be able to capture outcomes in both populations at the same rate. And that led to a slight reduction in our sample size, but is not something that's necessary in a match design because of the way that the design is functions. And so here in the propensity score stratification, we had, as again, I said, smaller sample sizes here, but because of the stratification approach, we're able to keep all of our cephalosporin population. And we saw the same, we saw one alert here, and we saw the same alert. So the alert was in the general model. It was still persistent when we had the general plus the indications, and it was in the high dimensional propensity score model. So what was this malformation? It was called bicornate uterus, and this is where I'm not a clinician, so I apologize to clinicians in the room, especially if I'm mispronouncing it. It is a rare malformation, and it cannot be diagnosed in infants. It's essentially, it's a malformation associated with the mother, and it's actually being marked because it's harder for that mother to deliver. And so we saw 6 cases in the exposed group, but we expected very few, which led to this large relative risk and an alerting. When we investigated this, we found all 6 cases were in the mother's record. And so one of the things that's true is when we look for outcomes, especially birth outcomes in secondary use data, we use both the mother's record and the infant's record. And that's because the infant often doesn't get their own identity in these data until sometime 30 to 60 days after. And so this is a possibility where we could potentially misclassify an alert. We expected none, but really we had none because this is mother's record here. But it does show the power to pick something up at very small numbers. The imbalance here, was like a 6-to-1 between the two of them. And we know that the Poisson model has greater power than the Bernoulli model to pick these things up. So it's actually not surprising that the Bernoulli didn't pick it up with a 6-to-1 split. And so one of the things that we thought about here was, sort of what we could learn from this and what we wanted to take away with respect to using these 2 different methods and potentially how we could learn about triage and how to perform triage. And so a summary of the empirical study results, because I want to leave some time for a few questions, is that we did not observe evidence that there was any increase in the first trimester risk of exposure to fluoroquinolones versus cephalosporins. We did see 2 alerts pop up in empirical data when none were expected. Both of them did not graduate to being actual signals. One, we believe, is due to some sort of issues with confounding control, but also potentially that outcome wasn't real, in the sense that we saw it appear often once, not again, and there was no serious sequelae in those particular infants. The other outcome was one that was in the mother's record, not the infant's record. We did have a very small sample size. So based back to our simulation results, we would consider ourselves underpowered to see small increases in risk, particularly in very specific malformations that were uncommon. But we also didn't see a lot of spurious alerts. And so one of our concerns too was that, everything's going to be alerting. We don't want to have that, right? So we were very concerned with making sure that we weren't going to be overwhelmed, and we didn't find that. So we have an active comparator setting here. And that also allowed us to ensure that our natural use of an active comparator can prevent a lot of spurious results that we could see. And so really briefly, our recommendations to the FDA for future work in this area were to use the Poisson model because it is more powerful, to use expected counts from a referent exposed or unexposed population, because we're using the Poisson model, that is compatible with a propensity score stratification or fine stratification confounding control approach, which can be used with the general model or investigator specified covariates or high dimensional propensity scores. When overlap is poor, we would suggest adding more of these components to basically to get to better overlap, to get to better exchangeability. We looked at a sensitive outcome definition, which is a single code in any care setting. And we have a preference for having 4,000 exposed pregnancies, but acknowledging that we still think, because of the dearth of information in the post-market for pregnant women in general, that we should still do work even when we have less than 4,000 exposed pregnancies, because some information, even if it is underpowered, is better than no information, which is often what we have now. And so I realize that last part was very fast. With that, I'm happy to take any questions, but I think we're very close to time. So I apologize for taking so much time with the presentation itself.
Thank you, Judy, for a great talk, very thought-provoking. I guess I'd be happy to open the floor for questions from 1 or 2 folks. If you want to just either use the hand function or the chat function.
Oh, I should put this back up.
So I guess one just while we're waiting for some, I guess one question I have, and it's more of a process question, is how often are you guys running this, and how's the interaction work with the FDA in terms of when you find a signal to the decision to either move forward with a confirmation study versus not? How does that process work?
So right now we're still in the piloting phase of this, in terms of, we did these studies and we're working through them right now. So this is the infant study. We're also doing a study of moms, so health of moms, that we're in the middle of, but we're moving forward toward potentially thinking about how to incorporate this into routine use. And when we've done this, at least in the pilot studies, the FDA is part of the process of doing that alert triage. So we make available to them information, especially when we can, because of sort of privacy preserving reasons, about the patient profiles, about some of the sort of follow-up information. So we look at things like, for example, how many of these outcomes that we see are being observed only once, how many of them are being continuously observed, some of those details and things like that. And so we work with them to decide, and we work with their clinicians, particularly to decide whether there are things that are worth following up or not. And so I'd say that that's like a case-by-case basis that we do it at this point. And we're still working on regularizing this process into the normal process for the FDA, but it's something they're very committed to. And for folks who are familiar with some of the US regulatory scheme, a big part of the Prescription Drug User Fee Act 7, which goes into action in October, is to incorporate this signal identification work more routinely into regulatory studies.
Okay, no, thank you. That's very interesting. Any other questions from the group? Oh, Krista has a question. Krista, you can unmute.
Can you hear me now? Can you hear me now?
Yes.
Okay. Great presentation. I just had one quick question. So for the practical example, you focused on exposure during the first trimester, right? Which for congenital malformations, like is the etiologically relevant window, but you were looking more broadly. And I was just wondering, how do you deal with that if you're also interested in exposure later on in pregnancy? Do you just run it separately? And then how do you deal with the adjustment for like the multiple testing, which is sort of inherent in the tree scan, or do you just look at exposure at any time? I was wondering whether you could talk a little bit about how to address that.
Sure. So it's something we talked about initially, and actually it's become more of an issue when we're thinking about our mom study, where we're worried about mom outcomes, because mom's exposure is not necessarily tied to congenital, like as you mentioned, congenital malformations being really heavily tied to the first trimester. And so we looked at that where the concern is will you be diluting any potential signal if you're adding in these second and third trimester exposures? So right now, I think when it comes to particular malformations, there is much more of an emphasis on the first trimester, but I would personally recommend that we actually look at them as separate subgroups. We can still do an accounting for multiple hypothesis testing in the same basically in the same analysis, as long as we're careful about how we tell TreeScan about that information. But we need to potentially keep the first and the second, or maybe second and third together, but keeping those two sort of stratified so that we don't potentially add in a bunch of basically noise that might drown out any problem that you might see. So I think it's doable. It's tricky. The other thing too is that exposures, as you probably know very well, they dive in the second and the third trimester. So there's not that many women who are actually exposed in the second and third trimester as women start to learn that they're pregnant and then decide to change maybe their medication practices. So we see these big dips in who's actually exposed in the second and third trimester.
Great, thank you.
So as we're approaching 1 o'clock, I'm just going to take this opportunity just to thank Judy for an excellent presentation and invite everyone to join us again next month for the monthly CNODES virtual seminar series. Thank you very much.
Thank you for having me.